So hi, everyone. We are super excited for our event today. It's our storytelling series part 2. We're focusing on addressing weight bias in sexual and reproductive healthcare. And we have some amazing speakers today and also an amazing host. The Medical Herstory team has been working on this event for quite a while, and we're really excited to finally be able to present it to you all. Go to the next slide, please. So before we begin, I'm going to do a quick land acknowledgement. So although we're located all around the world, which we can definitely see from all the amazing places everyone listed in the chat, I'd like to start off today by acknowledging the land on which myself and the university which Medical Herstory is founded on is residing on. So Medical Herstory acknowledges that our events and spaces for discussion take place in the traditional territory of the indigenous peoples, such as the Kanien'kehá:ka, on the island known as Tiohtià:ke, in the language of the Kanien'kehá:ka. The Kanien'kehá:ka are the keepers of the eastern door of the Haudenosaunee Confederacy. This island has, sorry, my apologies. This island has also historically served as a meeting place for other indigenous nations. We cannot begin to discuss patient advocacy, barriers to accessing care, or internalized stigma without recognizing the role that colonialization, white supremacy, and medical racism play in the social structures which healthcare as an institution is situated in. My apologies. I feel like I was so excited for the event that now I'm stumbling over my words. So a quick background for those who do not know, this event is organized by Medical Herstory. Medical Herstory is an award-winning youth-led international non-for-profit organization advancing and advocating for gender health equity through storytelling, patient advocacy, medical education, and undoing stigma. So we hold events such as these, we hold workshops, publish stories, and all of this with the goal of eliminating sexism, shame, and stigma from healthcare experiences and health experiences in general. So about this event, so today is, as I said previously, the second installment for our storytelling series, and there's 3 in total. So if you like this event, definitely check out our last one. It's coming out soon. So today we'll be highlighting the inequities relating to weight bias in sexual and reproductive healthcare to advocate for people of all sizes to have access to comprehensive and compassionate care. And we just want to quickly acknowledge that our event partner for this event is Oxfam, a global charity organization that focuses on fighting inequality and patriarchy to end poverty and injustice through empowerment, embracing inclusiveness, and demanding accountability. And before we begin, and I kind of hop off and let our speakers and lovely hosts take over, just a couple of quick Zoom rules. So please remain muted if not speaking. If you're comfortable, definitely keep your camera on. We love to see friendly faces. And also I think it's always way more fun to engage when cameras are on. And please do feel free to use the chat. So the first hour of this event is going to be a structured panel. So it's questions that we've prepared ahead of time. And then you're going to have about 30 minutes for an open Q&A. If you are interested in asking a question, please pop it in the chat at any moment. We'll write it down. And then from there, those questions will be asked in the Q&A. Yeah, so definitely use the chat option. And also feel free to, if you have any questions or concerns during the panel, to just type that in the chat. We also have active listeners present. So they're part of the Medical Herstory team, and they'll have active listener on their name mentioned. So please feel free to message them privately as well. If you ever need to talk to someone or just need to take some time away from the panel. Also, as always, please be very respectful and inclusive to everyone. This includes our speakers, our hosts, and also other people on the Zoom. And also, just a quick note, closed captions are enabled and you can activate them at any time during the event, and that's just located on the bottom bar of your Zoom. And a quick, sorry, I know I'm kind of talking a lot, but I hope that's okay. But a quick content warning, as always, very important, is that topics of discussion today may include sexism, racism, ableism, fat phobia, medical trauma, mental health, and other sensitive subjects. Medical Herstory does recognize the challenges of today's discussion, and we are extremely grateful for our speakers in sharing their knowledge and experiences. So please do practice self-care and take breaks if you ever need. If you do end up needing to leave the Zoom, please know that we will let you back in. So if you do need to take a break at any moment, feel free to hop off and we'll let you back in whenever you're ready. And before we go into our speakers, I just want to quickly pass it on to Devin, our lovely host from Medical Herstory.
Hi, everyone. It's so nice to see you all here today. My name is Devin Dietrich. My pronouns are she, her, and I am lucky enough to be the moderator for today's panel. I think weight bias is one of the most widely acceptable biases still seen today. And so I'm really happy to be able to be a part of this event and introduce these wonderful speakers who can help educate us more on weight bias in medicine and in patient advocacy, and how we can all, whether we are wanting to go into the medical profession as biomedical researchers, patient advocates, or even just compassionate citizens and community members, how we can all work to fight weight bias in our communities. So with no further ado, I'd like to start off introducing our first speaker, Dr. Asher Larmy. So Dr. Asher Larmy is a trailblazing transgender and non-binary general practitioner and passionate fat advocate known for their mission to end medical weight stigma. With over 20 years of medical experience and a personal history of navigating the complexities of being fat, Asher is a leading voice in the fight for weight inclusivity and fat liberation. As the founder of the #NoWay campaign and the self-styled Fat Doctor, Asher has used their platform to share their story, educate others, and inspire change. Through a successful podcast, training courses, and regular webinars, Asher is dedicated to empowering others and sharing their message of weight inclusivity. They now help people overcome the negative impacts of weight stigma and find peace and acceptance in their own bodies. You can find more information about them at the hyperlink in the bottom left corner. Dr. Larmy, would you like to introduce yourself and tell us a little bit more about how your journey towards patient advocacy with a focus on ending weight bias began?
Oh, it's always terrible when you're first and when you just had to listen to someone reading out your bio, which is so embarrassing. But yes, hi everyone. I'm so very honored to be here today to be asked to speak. To put everything into context, in May 2020, 2-3 months into the pandemic, I went by the name Natasha. My pronouns were she, her. I was a very I presented as feminine, and I was on a diet, and I was writing a weight loss blog. So that's where I was, May 2020. Now you can see that I go by Asher and my pronouns are they or he. I prefer they, but I'm happy with he. Just try not to she me. I don't mind if you do. It's fine. Accidents happen. I do it to myself all the time. I guess I was writing a weight loss blog. I went on a massive diet, been on many. It's not my first time. And this time kind of went like every other time. I lost a bunch of weight, and then I fell into a deep depression, and the diet went, to the wayside. And luckily this time round, a whole bunch of people from the anti-diet community came around alongside me, Reagan being one of them, and supported me to understand a lot more about why diets don't work. But then it went on to weight stigma, fat phobia, medical weight stigma. And as a doctor, I started to realize, I'm part of the problem, not the solution. This is no good. I need to do something about it. So I went from, really being quite invested in weight normative care and not really understanding my own gender, to somebody who is now really passionately advocating to the point of not really being able to work as a doctor anymore, because I feel so passionate about the fact that we need to end medical weight stigma in particular, but of course all forms of weight stigma. That's where I am right now. You've said everything else with that wonderful bio.
Well, you shouldn't be embarrassed of your amazing accolades, and it's wonderful to see how quickly, this your journey has been just since 2020. That's really wonderful. I will move on to the next panelist. So next we have Jen McClellan, who is a published author, founder of Plus Size Birth, and host of the Plus Mommy podcast. She helps people navigate the world of plus size pregnancy, shares tips for embracing your body, and laughs her way through the adventures of parenthood. With nearly 8 million page views, Plus Size Birth is the premier plus size pregnancy resource trusted by parents and professionals. The Plus Mommy podcast has over 245,000 downloads and was named one of the best pregnancy podcasts by The Bump. As a public speaker, Jen has been featured at numerous events, including presenting at the National Institutes of Health, where I work, which is awesome. Jen is also a certified childbirth educator, a wife, and a mother to a charismatic 12-year-old. And again, you can find her Instagram at the handle in the bottom left. Jen, would you like to introduce yourself as well as tell us how you became passionate about fighting weight bias?
Yes, thank you so much for having me, and what an incredible panel. I'm honored to be amongst these presenters. I found out I was pregnant in 2010, and I went on to Google. I think like a lot of people do once they find out they're pregnant. Only as someone existing in a larger body, it was like all doom and gloom. I read that I would have a cesarean birth, that I was a horrible person for wanting to become a parent as someone who exists in a larger body, and it was really defeating. I went on to have a completely healthy pregnancy. I was incredibly supported switching from the obstetrical model of care to the midwifery model of care, where it was life-changing. And I felt like for the first time, I had a care provider that touched my body with compassion and empowered me to believe that I was healthy. This was like my first introduction to health at every size in 2010. And I, again, had a healthy pregnancy. I gave birth on my knees in a hospital and was forever transformed. So when my son was about 4 months old, I was like, surely I couldn't have been like the first fat person to have such a wonderful, healthy, supported experience. Why aren't there more stories like mine? Why are there no positive resources online? There were just a small few. And so I started blogging, having no idea how to even blog, let alone knowing that that decision would change my whole life. And in April, it marks 12 years since I started. Immediately, the blog took off, social media exploded. So I realized that this was a conversation that wasn't happening, and it needed to be happening specifically around pregnancy. And so I became certified as a childbirth educator and started traveling the country speaking, and the rest is really history. And I'm really honored to be a part of this movement of creating change for people of size and specializing in pregnancy. So thank you for having me.
Of course, that is such a warm and fuzzy story, and I'm so glad to hear that your whole pregnancy was smooth and healthy. And it's wonderful that you've taken your own experience and began to transform positively the lives of so many others. I will move on to our third speaker, Jessica Wilson, who is a clinical dietitian, consultant, and author of the newly released book, It's Always Been Ours. Her experience navigating the dietetic fields as a Black queer dietitian have been featured on public radio shows and in print media, including the New York Times. Jessica has worked as a clinical dietitian since 2007 and is acutely aware of both public health and medical framing of eating, healthy eating, and obesity has contributed to disordered eating and self-blame. She speaks openly and candidly about the harm caused to our patients by designating individual identities as risk factors, rather than targeting the structural inequities and violence that marginalized individuals must endure. Jessica, would you like to introduce yourself?
Sure. In addition to that, I have loved everyone's journey so far. So thanks, Asher, and thanks, Jen. I look forward to Reagan's as well. I started this journey as a college health dietitian. So yay for college health and all the students here and organizing this event. I started wanting to talk to people who ate food, and instead in college, that's really rare. I had a lot of eating disorder patients and I was not happy about it. I did not want to do that work. And a lot of us, most of us are not taught how to do that. So it was a steep learning curve. And I had my first fat clients, and even just like typical size folks with restrictive eating disorders. And all of a sudden, both me and the medical doctors realized that we knew nothing about eating disorders and quote calories in, calories out. So that began a journey. I started in health at every size and quickly realized that that was not a community for me in the early mid 20-teens, 2010s. It was very much second wave feminism all over again, but in health at every size spaces. It wasn't like, the easy word is not, it wasn't intersectional. It still really elevated health. So you could be fat if you were healthy. And if you were fat, you should be trying to be healthy. So you should be exercising, you should be eating intuitively. There were a lot of battles within ASDA, which is the organization that trademarks the health at every size principles. And so I left health at every size and started to do more radical organizing, mostly among queer and trans folks of color who were also fat folks, and really just hearing about what people needed, because health at every size wasn't it. And so since then, I have been, continuing to advocate for my clients. Mostly I talk about anti-fatness as anti-Blackness now. So that is more of what is in my book. And I also work at a queer and trans health clinic, writing their eating disorder and weight stigma policies, because I'm sure we'll get to how often gender care is gatekept by BMI. So folks over, it's typically a BMI of 35 are denied access to gender affirming surgeries and care. So those are my work right now. And so my book, It's Always Been Ours, is really about Black women, but also applicable because anti-fatness is anti-Blackness. And then again, how we're never addressing structures and systems. We're talking about people as problems. So that's that.
Thank you so much. That you bring such a wonderful wealth of experience and perspective that this conversation would be sorely missing something if we did not discuss intersectionality. And also, I think it's great timing considering that this week is Eating Disorders Awareness Week. So we're very happy to have you here. And last but not least, I will be introducing Reagan Chastain, who is a speaker, writer, researcher, board-certified patient advocate, multi-certified health and fitness professional, and thought leader in weight science, weight stigma, health, and healthcare. Utilizing her background in research methods and statistics, Reagan has brought her signature mix of humor and hard facts to healthcare, corporate, conference, and college audiences, all the way from Kaiser Permanente to the Diabetes Education Specialist National Conference to Amazon, Google, Dartmouth, Caltech, and CanFit Pro, a fitness education company. Author of the Weight and Healthcare newsletter, the book Fat, the Owner's Manual, co-author of HAES Health Sheets, and the editor of the anthology, The Politics of Size, Reagan is frequently featured as an expert in print, radio, television, and documentary film. Welcome, Reagan. Would you like to introduce yourself?
Sure. Thank you so much for having me. And again, I'm incredibly honored to be part of this panel and so grateful for the work that everyone is doing. My personal journey started almost 20 years ago. I was looking for, at that time, the best diet, having had a history of yo-yo dieting. And because I'm a massive nerd, I decided to start with essentially my own literature review. And so I wasn't in school. I had a corporate job. I didn't publish. I literally just, this is the kind of nerd I am. And so in going through the research, found that there wasn't a single study where more than a tiny fraction of people were actually succeeding at long-term significant weight loss. And that started me down a path of learning about weight science and weight stigma that continues to this day. In 2008, I was ballroom dancing competitively. And up to that point, I really had conceptualized this as sort of an individual journey. And as a ballroom dancer, the fat phobia I faced led me to realize that this is a group of people who are being oppressed. It wasn't like just a personal situation that I was having. And that got me started blogging at my original blog, Dances with Fat, and kind of thinking about these things and writing and speaking about them. And so currently a lot of my work centers around practitioner education, centers around helping higher weight people navigate healthcare, and centers around doing harm reduction work in, as Jessica beautifully explained, is a deeply flawed system with incredible intersectional injustice. And so again, super grateful to be here and excited to talk about this today.
Thank you so much. Yes, I'm extremely excited for all of these perspectives on how we can transform these conversations and discussing how weight bias is a systemic rather than a pathologizing people. So after these introductions, I'd like to get started with our very first question. And then after this will be about 45 minutes to an hour, and then we'll move into the open Q&A. As always, to the audience members, please feel free to put any questions you may have into the chat box, and we can get to those later. So first off, I would like to ask, kind of just as an introductory question, but what does weight bias look like in the medical setting? What does it look like within patient-provider interactions and relationships? Maybe we could start off with Dr. Larmi being a doctor. I know you didn't want to go first, but
well, I'm not gonna use fancy words, and I'm not gonna try and be clever about it, because it's afternoon here and my brain's not switched on anymore. That's an excuse. But weight bias just it's so complex, and it's in everything that we do in medicine and in healthcare. It's almost like it's the foundation. You talked a little bit before about how I think it was Daria who was saying about racism being the foundation of healthcare, and I would say that in my experience, racism and sexism and capitalism, and definitely weight stigma altogether, make healthcare a very much like tiered system. And at the top tier are people who are white, affluent, and educated, and cisgender, heterosexual, and fit. That's the top tier, and no matter where you are in the world, you probably get good healthcare if you're in that group. And at the very bottom, you have people who are Black, and also other racialized groups, but especially Black, and especially if you live in the States or in Northern America, I think especially that in that case Black or Indigenous. If you're transgender, if you're queer, and of course if you're fat. So that's the bottom tier. And when you're in the bottom tier, what happens is you just don't get any good healthcare. Healthcare should be all about what's in your best interest. It should be about what doesn't harm you, right? Doctors shouldn't be harming you. It should be about patient autonomy, your right over your own body, and it should be fair, it should be equal, and there should be no discrimination. And if you are in any of the groups that I mentioned, especially if you hold multiple marginalized identities, you are not entitled to any of that. Your healthcare is not in your best interest. Your healthcare is almost always harming you. Your healthcare does not entitle you to autonomy. If you to have control over your own body, you have to have agency. You have to be able to make a decision without, fear or coercion or manipulation. And yet there are doctors everywhere saying, if you don't lose weight, you can't have this and you can't have that. That is the definition of coercion. So there's no autonomy, there's no agency. And of course, medicine isn't fair because medical practitioners have a lot of anti-fat bias, racism, and in fact, essentially, medicine is white supremacy. It's furthering the white supremacist agenda. So it's so complicated, to say, what does weight bias look like? Weight bias basically is, it's intersectional, but it is essentially your healthcare is second tier, third tier, fourth tier. You do not get anything the way that you should. You don't get anything that you deserve or that you're entitled to. And I'm sure I could expand on that, but I'm very conscious that I, need to stop talking. And I'm sure other people will have different perspectives. But as far as I'm concerned, weight bias equals zero healthcare or zero adequate healthcare. There you go.
Thank you. Yeah, I'd like to ask Jessica, being a dietitian and having worked in the medical space as well, what are your perspectives? Particularly, what are some specific examples that come to mind as being, yeah, this is what happens, and which people might not recognize or acknowledge from the physician or dietitian standpoint?
I think the easiest way to look at, well, actually, let me just say that Asher said so many things, so I will just back those up in the things that I'm saying. So I really appreciate that. I think the pathologizing of people is really where it is for me. So people are not people. People are chronic diseases. They're, they have high blood pressure, so we have to solve it. Like, people just are problems to be solved. They need to lose weight. Their bodies are a problem. So they get sent to a dietitian to fix their body, to fix their problem, which is inherently fixing their body. So of course, we're impacted by, looking at a medical provider's diagnosis, and I end up, fighting with medical providers so that people can make their own choices about their own bodies. But really what it comes down to is just the lack of humanity in the medical field, and how we are not, talking to people. We're talking to people with problems, and inherently they are the problem. So I'd say that is like the patient provider, like direct interactions. And then I also would love to echo the white supremacy is medicine. Through writing a chapter on health, I really got to tease apart how white supremacy is really structured, what health looks like, what health is. So just to echo everything that Asher has said, how healthcare indeed is white supremacy and how people will never, ever fit. And again, so those would be Black folks, fat folks, trans folks, disabled people also, because health is a social construction that we have all agreed upon. Yeah, I'll take up less space on this question.
No, take up as much space as you need. You have wonderful perspectives. I would like to invite Jen and Reagan. Do you have, from the patient perspective, how have you seen weight bias manifest in your interactions with medical professionals?
I can go. Oh gosh, echoing everything that everyone has said, specifically working around, reproductive healthcare. So many BMI restrictions that people who want to become parents aren't even allowed to receive fertility support. And if they are, they have to fight horrible stories. And I'm glad that we had the trigger warning before we even began, but of people who can finally fight for something like IVF, but then are not received anesthesia for egg retrieval and have to go through that without anesthesia. Echoing what has been said about how Black people and people of color are treated so differently in our medical system. We have a higher rate of Black maternal mortality, and Black babies and Black pregnant people are dying because of how this system is set up. Higher rates of stillbirth. It is heart-wrenching and awful, and needs to be talked about, but just even receiving the ability to get support in becoming a parent, there are so many barriers. And then once you are in the medical system, there's so much misinformation given to people by care providers that isn't even evidence-based information. People during pregnancy being told to lose weight, which the Institute of Medicine and the American College of Obstetricians and Gynecologists says, no, this is not evidence-based recommendations, and could go on and on about the evidence of the harm that is being done to people. And I'll turn it over to Reagan, because Reagan has so many amazing tips on just accessing and interfacing with healthcare, and some wonderful ways to advocate for yourself around that too.
Thanks so much. I think for me, in addition to everything that's been said here, it's about a system of oppression. So it's a system that when we talk about weight stigma, we often think about practitioner bias, both conscious and unconscious. And of course, that's an issue, but there's also structural bias. The fact that the research doesn't include fat people. And then for those who have multiple marginalized identities, that's multiple more chances that you are not included in the research that creates the systems, the processes, the best practices, the tools, the pharmaceuticals. And so we've got a system that creates weight stigma and weight cycling and healthcare inequalities. And then it blames the harm that come from those on fat bodies. And then it uses that harm as an excuse to create more weight stigma and weight cycling and healthcare inequalities. And so it's a broken system that harms fat people at every point and does the most harm, again, to those with multiple marginalized identities and those at the highest weights, and in particular, Black folks, as just again, to reiterate, weight stigma is rooted in and inextricable from anti-Blackness, continues to disproportionately impact those folks to today. And so we have to break the system completely in order to even have a chance of access, inequality, and parity, within a system that's supposed to care for folks.
Thank you so much. Building off of Jen's point, and I'd like to ask everyone to contribute, but zooming in on weight bias and size stigma, particularly within sexual and reproductive health. Could you share more from that perspective? What does that look like?
Can I just say something really quickly? And I promise I'm not going to keep hijacking the conversation. But I think we've all been talking about how the importance of anti-Blackness. And I've done a lot of research into the history of medicine. I'm a bit of a history nerd, and I love learning about the history of medicine. And I've spent a lot of time reading about the history of modern medicine, how it came into being. And I think it's really important to acknowledge that modern medicine was created at a time when people were, it was created, and I'm just going to say it, it was created to oppress Black people. The purpose of modern medicine has never really been about healing people. Plenty of people were healing people a long time ago. The purpose of medicine has always been, especially public health and reproductive rights and various other parts of modern medicine, has always been, the sole purpose was to oppress Black people. And if you read Sabrina String's book and Deshaun Harrison's book, which I'm sure we'll mention at some point in time during the day, you will see that when we began to associate fatness with Blackness, that's when we started to try to oppress fat people as well. And I just wanted to put that in there. When we say it's rooted in anti-Blackness, it is literally, the history of medicine is rooted in anti-Blackness. And that's where our medical profession's hatred of fat people comes from. It's because fatness is associated with Blackness. And I just wanted to put that in there. And I'm now going to leave everyone else to answer that question, because I'm sure you've got much better ideas.
You bring up a very important point, particularly with the history of Dr. Sims conducting, quote unquote, the father of modern gynecology, doing non-consensual experiments and work on enslaved women, largely enslaved Black women. So that is a very important point I'm glad you raised. And it's particularly relevant to the field of obstetrics and gynecology. So just to repeat the question, how does weight bias and size stigma affect sexual and reproductive health specifically?
I can touch on that a bit more. We've had so much research to prove that weight bias has been occurring in healthcare for decades, right? But we didn't have studies to show that it was occurring within the maternity care until about 2020, which is just like, right? And so I've interviewed some of the researchers on my podcast, and basically they proved everything that everyone's been saying, that weight bias is happening in medical care, and it's detrimental. It is being connected to all the higher risks that we see. There was even a study looking into higher rates of gestational diabetes for people who have experienced weight bias. And so you're wondering, like, oh my goodness, like the stress and the pressure that has been put on people throughout their maternity care is detrimentally impacting their overall health and wellness during pregnancy and the health of their babies. So now we have this evidence to prove that it's happening in the reproductive world. And there's also new research being looked at all the barriers with fertility treatment. So I know this is very heavy topics that we're talking about, but there's also a lot of hope and good that is happening and new conversations that are happening. And a lot of the younger OBGYNs that I interface with want to have these conversations and want to be size inclusive and want to know what that looks like, because ultimately we have evidence to prove that people of size do have overwhelmingly healthy outcomes during pregnancy. And a lot of the things that we see pushed in the interventions during childbirth, including cesarean birth, have a much higher risk during postpartum. So we want to work even more to help people have healthy outcomes during pregnancy and birth, to reduce their risks of having poorer outcomes, especially during postpartum as well.
And if I can jump in and just add to that a little bit, going back to looking at the research, for example, the research on, for example, emergency contraception shows that the pill form is not as effective and at some point becomes ineffective for higher weight people. Copper IUDs don't have a difference in efficacy, but are much more difficult to get, and people can tend to face weight bias trying to get them. Also, trans and non-binary people not in any way included in that research. People of color underrepresented in that research. And so, again and again, we see that it's considered, there's this idea within medicine that if anti-fatness is the reason, then inequality is acceptable, right? So if we can blame fat bodies, then we can not include them, give them less care. And again, that goes back to anti-Blackness, and it is doing the most harm always to the people who are multiply marginalized and to those of the highest weights, because they have the least chance of being included in the research. And so, every area of sexual and reproductive health, when we talk about quote unquote research-based treatment, which has many of its own problems, still that's not what people are getting if they're not in this like thin white cishet currently able-bodied state.
Reagan, I'd like you to expound on something. You mentioned the evidence or the research-based therapies and how there are problems with that. Could you expound on that some more?
So in terms of emergency contraception, do you mean?
Or just emergency contraception, or how research-based interventions might not be the appropriate methodology?
Oh, got it. Yeah. So research is incredibly complicated to undertake in a way that is equitable, in a way that is helpful, especially when it's rooted in a system that is already broken, that is already inequitable. And so, but just from like the most basic research methods practices, inclusion of the sample gives you extrapolatability. So if you're not included in the people who are studied, we cannot extrapolate. And when I was in school, we called it the 150-pound white guy problem, meaning white cis guy. That's who the research is performed on. That's the population that was typically included. And then there was an assumption that, oh, we just extrapolate to everybody. And that's simply not the case. And we're learning more and more about that and still not correcting the problem. And so research still has this problem of, the quote unquote normal weight, cisgender, white person who gets studied, and then an attempt to extrapolate. The COVID vaccine is an interesting example in that it actually included fat people at the rates that we exist in the world. And that's a bit groundbreaking that they had an idea, because previous vaccines hadn't included fat people, and it was found later that the vaccines didn't work as well. Before you talk about vaccine needles, and it gets very complex, and I won't go down that rabbit hole, but in general, we've got a system where it's broken anyway, and even what we're doing, within the research in that broken system is still further breaking the system.
Thank you so much. Yeah, I think it's really important to clarify that, because so many people might think, oh, we have research-based methods, this must be good. But then there's actually this whole other layer about what good research entails. And it's not necessarily just case control studies, but it's actually who are we, what is our sample size looking, and from what demographics and other factors of privilege are we considering in this research? Dr. Larmy or Jessica, do you have anything to add to this?
I actually found a study that did include people of all weights. The cutoff, well, there wasn't a cutoff, but they included every BMI, and the highest BMI was 122. And it was a mixed sample of white and black women. No, they were all cisgender women from what I could tell. It's always difficult because they don't specify, but it was quite amazing, actually. I thought that was quite groundbreaking. And it was just a simple survey, questionnaire-based study. A group of women asked, fat women, they were all fat, asking them about barriers to accessing gynecological cancer screening. They include breast screening in that as well. So basically pap smears, mammograms, things like that. And what they found, you would not be surprised to hear, is that the higher the BMI, the less likely people were to go and access the screening. And actually, that translated into fewer people actually having these very important examinations, so pelvic exams, breast exams, etc. So there was this perceived barrier of care, which was that I'm stigmatized, and therefore I am avoiding the doctor or the health screening, which is not surprising. I mean, all the evidence shows that. Medical avoidance is one of the most common issues related to weight stigma. Is, people don't trust their doctors or their healthcare professionals. They're harmed by them, they're traumatized by them, and they don't want to go back. Really important for this kind of screening. And the answers that they gave, and of course, as I said, the higher the BMI, the more likely this was fear of being stigmatized, fear of being weighed, embarrassment around being weighed, and also kind of unsolicited weight loss advice, which is very common, especially even when you go for your pap smear, because your legs are out and someone's fiddling around in there, and the last thing you want to hear is, so have you heard about Wegovy? And then the other thing was like failure to have the right size medical equipment, and medical equipment is not fit for purpose, especially like silly things like couches, the beds that are so narrow and you can't fit on them, and that's so uncomfortable when your literally legs akimbo, and not having the correct size speculum, stuff like that, really basic stuff that is so easy to deal with. And yet that was what was preventing people from getting life-saving screening. And what that translated into was people were having fewer examinations, in spite of the fact that they all reported a moderate or a serious concern about gynecological cancers. So it's not like they didn't care. They did care, but they were more afraid of being stigmatized, and that put them off. And I thought this was quite an important study that basically summed it all up for me. And I liked the fact that they included, well, not everybody, but they made a real attempt to include people. All of these people were wealthy in the sense that they had healthcare cover. It was based in the States, so they had insurance. So insurance wasn't putting them off getting, and of course, you take away that insurance and then you have this whole other thing that you have to worry about. And that's a completely, you know, that just adds another layer. But I think that just goes to show medical weight stigma is actually killing people, literally killing people. And from another perspective, I've recently been talking to someone, it's not the first person I've talked to, who went to the doctor complaining of some vague abdominal pain and, you know, quite a few worrying symptoms for weight loss and complete loss of appetite, to which she was patted on the back, said, congratulations, that's wonderful, keep going. And they did this for 2 years. And during that period of time, she grew an ovarian tumor to about 20 centimeters big in each dimension. And then when they finally diagnosed, so when someone finally touched her tummy, they found the tumor. It was very obvious because it was sat right there. And then they put her off another 3 months, making her jump through all sorts of hoops to get this life-saving surgery. And by the time they operated on her, her cancer was terminal and it's not treatable. And she was given 4 years to live, and she's halfway through year 3. And that's the other way that weight stigma manifests itself in reproductive care and women's health. There you go. That's a couple of examples.
I'll only add quickly that for trans men and cis women, the weight limits for anesthesia, which people are willing, basically not able to use for egg harvesting, is something that I've seen as well. So like whatever access you have to a clinic, be it a university or, you know, a private clinic, you know, it is up to the clinic for their willingness to perform anesthesia on both trans men and cis women. So add that one. And then Asher already mentioned the history of anti-Blackness, and I'll say right here, for folks who are in this field and have not researched the history of gynecology, I highly recommend doing so. We would not know the things that we know today if enslavers had not, well, and medical doctors, I don't even know if they were actual doctors at the time, used enslaved women to, you know, see what happens when, you know, a cesarean is performed, to see, you know, what speculums, you know, are used, you know, for and how well they're used, all the while not giving anesthesia to Black women, which continues today in the, well, every day, and in the labor and delivery process, especially because we're not given, you know, access to, oh gosh, the people who have had babies, what is it now? I'm forgetting. Pain medications.
Epidural.
Epidural.
Yeah, see, thank you. Yeah, I don't have children. Epidurals and other basically things to ease their pregnancy, so just not given access. Those are the only two things that I would add.
I think some amazing points have been raised, particularly with this, you know, wrong me once, shame on you, wrong me twice, shame on me. And so it creates this, well, why go back to a place where I'm already feeling even worsely marginalized and stigmatized than the just our community culture already does. So transitioning from Jessica, there, I actually want to zoom in on the topic of intersectionality and size stigma. So anti-fatness, as we've discussed, intersects extremely closely with anti-Blackness, anti-disability viewpoints, and very much affects a number of different marginalized identity communities, including the queer population, transgender population, et cetera. How how does intersectionality affect weight bias? Can we dive into that a little bit further? Of how do you see these identity factors being exacerbated, or the situation being exacerbated when you fall into multiple communities where your bodies are under-researched, under-respected, overlooked?
I'll start really quickly. I'm being very mindful of lived experience. So as a Black woman, but also not a fat person, it's a balance that I'm deciding between all the time. But I will say here, this is something that I saw discussed more often in the Health at Every Size community than others. So a lot of what fat Black folks, including Dr. E.K. Dauphin, were saying for a long time in Health at Every Size community and not believed, is that fat white women were looking to be respected and be seen as human in a doctor's office, to not be treated like Black people are in a doctor's office. But we're just unwilling to have those conversations in the 20 teens. But I see more folks like Dr. Deb Burgard willingness now to say, yes, that what was happening. Like we were, being treated like Black folks in the doctor's office. And what we wanted was to be treated like thin white people. So this was a lot of their involvement in Health at Every Size and that research. And weight stigma research is great. Like that is something that everybody, agrees on. And these other things were going on behind the scene, which is why my attempts to integrate like Eric Gardner's death. So his death was blamed, on his fatness for the reasons that he died primarily. Like it was his fault, because if he hadn't been fat, then he wouldn't have been smothered to death. And so I'm like, so these things like the over policing of both Blackness and fatness, like, can we have these conversations? Initially it was no. More often than not, now with the new leadership in ASTA, the answer is yes. So I see that and saw that specifically there. I'm looking at the question is what's happening. Disability plays in, of course, because fat folks and Black folks are historically denied both healthcare, and Black folks are more likely, because of our societal structures, to not have access to healthcare. And with a lot of that comes access to disability care. So I think of folks whose, mobility devices only come, to a certain, only support like a certain size, or they're only like a certain type of width, crutches, wheelchairs, blood pressure cuffs, like all of these things are impacting, whether or not people get care. Intersectionality affects weight bias just because there becomes 2 reasons or 3 reasons to, dismiss somebody as not feeling, pain is not fitting into our, medical model of health. And then, of course, again, for trans and non-binary folks, I've already mentioned, we've discussed a bit, that folks with a BMI over 35 are often denied gender-affirming surgery. And so what we really see here is deciding what trans masc people get to look like. Because when there's a BMI cutoff, right, people get to look trans if their BMI is under 35, because they have access to all of those, surgeries. And for folks with a BMI 35 and over, it becomes very clear now that those surgeons are making this choice. So I always say, when it comes to like surgery, it talks about like outcomes and the health of the patient, and whether or not they can say care for their wounds afterwards. I've heard that for bottom surgeries of fatter folks, like, we're concerned that people can't reach or whatever it is. But I always say, like, if somebody didn't have arms, you wouldn't be, worried about that. You would still give that person surgery because they could get support. But what you're doing here is really saying, we don't care for folks with a BMI over 35. So all of those I see in the work that I'm doing right now.
Would anyone else like to add to that?
I can echo what was just being stated as well for the LGBTQ plus community having access to becoming pregnant, right? So a lot of BMI restrictions there. I will say that more and more home birth midwives are providing fertility support, including IUI, which is the interuterine insemination, but you still have to, have the ability to get pregnant and have a pregnancy, whereas you wouldn't need as much oversight and support where you would need, to work with a fertility specialist. So for just so many barriers there for getting pregnant as well for people. And I will say for Black people and what is happening with the just shocking maternal mortality rates, there is a really powerful documentary that came out recently called Aftershock that really dives into that and the racism in maternity care as well. That's really powerful. But yeah, we see this so much. And as a white person with privilege, I always try to say that yes, I exist in a marginalized body, but I have so much privilege. And I feel like the more I talk about that within my community, it helps others to start having this conversation as well. So using that whenever I can, and then shutting up and sitting back as well. So I will do that now.
Like Jen, I have a lot of privilege in this space, so I'll keep this very brief. But one of the things I want to point out is how this ends up at the end of the day being eugenics against Black communities, disabled communities, queer and trans communities, and fat communities. I was part of a broad-based coalition that helped rewrite California's care rationing protocols for COVID. And because often these say if there's not enough equipment, then these are the first communities to not get care. And sometimes it's very direct in terms of disabled communities, and other times there's a lot of like backdoor ways that communities of color are targeted. And so it ends up becoming, again, an issue of a history of eugenics that has been perpetrated against these communities by the healthcare system that then gets perpetuated in this way.
I just wanted to echo exactly what you said, Reagan. I think we have to understand that the history, again, of modern medicine is rooted in eugenics. When medicine was being birthed, or modern medicine was being birthed, there were people that were focusing a lot on pathology, and at the time infection, because we suddenly learned about these things called germs. But then there was this other group of people who I guess were like the founding father of genetics. This is eugenics, turned into genetics. But at the time, eugenics was all about, again, anti-Blackness. First and foremost, it is about white supremacy. So what we have to understand is that modern medicine has been used or is part of, is complicit and perhaps even instigating eugenics. So we don't want Black people to exist. And sorry, when I say we, you understand, I don't mean me, but I mean the medical profession. Ideally don't want Black people to exist, fat people to exist, disabled people to exist, queer people to exist, trans people to exist. And it's obvious, you just have to look at social media. The world doesn't want us to exist. Again, I'm someone who is extremely privileged. I'm a small fat, I'm transgender, but otherwise I'm white and I'm rich and I've got nothing to complain about, but I experience it in my daily life. Therefore, people who are fatter than me, people who are Black, people who are disabled, etc., are experiencing it more and more and more. But ultimately, what we're saying is, we don't want you to exist. And so we'll do whatever we can. We'll stop you from being able to get fertility care. We'll stop you from being able to get pregnant in the first place. When you are pregnant, we won't take care of you. So ideally, you'll die. And this sounds really awful, and perhaps I'm being too harsh, but in an ideal world, you'll die. And if you're a Black person and you do manage to give birth and you do survive, chances are there's the school to prison pipeline. So we'll find another way, that backdoor way that Reagan was talking about. But ultimately, we are looking about oppressing and ultimately just doing away with groups of people. And reproductive care, I think, is one of the ways that we see it the most. From a gender affirming care perspective, like what Jessica was saying, it brought tears to my eye, because I was just literally tweeting about this today, what it feels like to be a trans masculine person who has a relatively large chest, really struggles with binders. If you're bigger, having a binder is harder, will never qualify for top surgery. And I'm stuck with these things. And there's a part of me that just thinks, okay, just live with it. Like live with the fact that you have breasts, you know, just accept the fact that having breasts doesn't mean you can't be a trans mass person. But I can't tell you the levels of gender dysphoria that makes me experience, because ultimately I'm a human being, and when I walk down the street, I don't want to be judged or humiliated or teased or targeted. And again, I'm not that fat, and you know, people just read me as female, as woman, and I don't tend to get that much harassment. But you know, it gets harder and harder and harder. I think if you're a trans femme, it's even harder, because people see me and they just see, you know, tomboy. But I think if you are trans femme, people see you as a, and I hate to say it, but you know, fat man in a dress, which is an awful thing to say, but ultimately that's how people view us and that's how people treat us. And that is, at the end of the day, it's, I keep saying the end of the day, it hurts. It really hurts. And I cannot express that in any other way as just except to say it really hurts. And I don't know how to deal with that. I don't have an answer, but it is my reality. And it is definitely the reality of people who are much more marginalized and oppressed than I am.
Ash, I would just, Dr. Lemray, I would just like to say thank you so much for sharing your lived experience. I cannot imagine how difficult that is, and I really am just grateful for each of you and bringing this very vulnerable side to this conversation, which I really think is really enriching it. And thank you so much for sharing that. A lot of you have brought up this history and how it has evolved from a history rooted in eugenics, rooted in exploitation of people from marginalized communities. Coming from that, in what ways, you know, looking back from where your journey with patient advocacy for weight bias has begun, or even farther back, in which ways have you seen progress? And in which ways do you think that we most need to, the most notable gaps, whether that's in patient care systems, policy, what do you see? How have we improved, and how can we still get better?
I can jump in from the maternity care perspective. I mean, when I started doing this work over a decade ago, we didn't even talk about size-friendly care providers. You know, there were a lot of conversations we weren't having our size-friendly doulas or midwives. So I think that there's now a conversation happening. There's more awareness of making sure, and not always, but like things that I tell people when they're searching for a size-friendly care provider is just the basic of having a blood pressure cuff that fits. Because if it doesn't, you know, people are being told they have high blood pressure, which can lead them on a track for induction and all these other things that aren't always medically necessary during pregnancy, having gowns that cover people's bodies. We are seeing progress. We're seeing some states like Colorado that opened up their state regulations around BMI restrictions at birth centers and got rid of them. And so people are being cared for on a case-by-case basis, which is what it should be, because we know that people of all sizes can have healthy pregnancies. So we are seeing some progress there, but it is shocking how much just misinformation is still being spread. And one that is really polarizing is people being told that their vagina is too fat to birth their baby. And I was horrified by this, and anecdotally have heard it so many times, but I'm like, okay, this can't be a thing, right? And so I hired a researcher because I just wanted them to dig into all the evidence. And it's not. The researcher pulled evidence to show that while there is a small increased risk for shoulder dystocia, which can be handled in the birth setting, it actually takes less time for a person of size to birth their baby, to give birth, than for people in smaller bodies, but it can take longer for the person to progress during labor. So that's why they say, oh, well, we're taking too long, we're on the clock, cesarean, here we go. So we know, and there are studies to show that it can take longer for people in larger bodies during that laboring phase. So there is now more time is being allowed. So I think we're seeing, like, you know, awful, horrible things are still happening. Evidence-based information isn't being used, but yet we're screaming from the rooftops. There is evidence to show if you give someone a little bit more time, we can help to reduce the very high cesarean birth rate as well. So it's a mixed bag, but I've definitely seen conversations happening and pushback from consumers that wasn't happening for so long.
I can say most of my time is spent with healthcare practitioners. And so when I started giving these talks in 2009, the audiences, and in particular the Q&As, were like hostile, contentious. People yelling at me, people walking out, people completely unwilling to talk about these things at all. And I have seen progression over time of now more people are, and often in the early days, one person with authority would bring me in and everyone else was forced to come. And now I'm getting more people are requesting this education. People are arriving with some information. People are looking to figure out how they can do better for these patients. And that's heartening to me. It's too slow, and it again continues to leave behind the most marginalized people. But there is progress. And I think there's a lot of areas where we can improve, but in general, this idea of health as a definition, that we have this single definition, we put people in and out of it, and then we judge them based on their proximity to this stereotype of health that's again rooted in this thin white cishet current able-bodied youth stereotype, continues to do a complete disservice to really everyone, but the most disservice, as always, to the most marginalized people and those at the highest weights. And one thing I do want to point out is I think it's important to know that what's happening right now within the weight loss industry is a push to co-opt the work and message of anti-stigma activists, many of whom have been working on this since long before I was born, with far less privilege than I have, and to use that message to sell weight loss, right? And to take over and become the voices of anti-stigma. And so I think we have to be really, really careful about that, because it's pretty insidious. It's often not clear, and well-meaning people, are going around thinking that saying person with quote obesity is better than saying fat or higher weight. And that's simply not true. That's about diet industry wanting to make simply existing in a higher weight body seen as a chronic lifelong health condition for which they can provide lifelong quote unquote care and treatment. And so just keep your eyes peeled for that, keep your senses open to that, because it's something that's happening a lot, and they're doing a very good job of doing it very insidiously.
One thing I think that we have gone backwards in, unfortunately, or perhaps haven't progressed. About 100 years ago, there was enforced sterilization. I don't know how many people are aware of this history of enforced sterilization, almost uniquely taking place within the Black community, the Indigenous community, and in disabled community. There were states, in fact, California was one. I think Virginia was one. There was a few other states where this was happening en masse, and women, cisgender women at the time, were being sterilized against their will, again for the purpose of eugenics. It actually only stopped happening in prisons in California around 2010 or something like that. So they were still performing enforced sterilizations in prisons in California and in the 21st century. So I think what we've seen is this kind of, again, this desire to decide who we will allow to procreate. And again, this is based in white supremacy, so it's about furthering the white race, and whiteness includes more than just skin color or race. But and so what we're seeing is it's just manifesting itself in different ways. Once upon a time, we just enforced sterilization. We can't do that anymore. So now we have limits on fertility care, etc. And Jen's giving me great hope that perhaps it will improve, but it's not happening quick enough. And certainly in the UK, it's getting worse and worse and worse and worse. And now, of course, there's been a huge reversal in reproductive rights and control again over our bodies. And so, you know, it feels like a 2 steps forward, 1 step back kind of situation here. I still think that one of the major issues is our autonomy over our reproductive system. And that applies, again, if you're trans, if you're, you know, if you're queer, it's going to impact you more. If you're disabled, it's going to impact you more. But actually, for everyone, you know, if you're in a fat body, you often don't get a chance to have children. In the UK, you can't even adopt. You can't even foster a child if you have a BMI over 35. So that you just cannot be a parent. And I think that's just because they don't want fat parents having children, because fat parents produce fat children. It's called genetics. So yeah, that I think we've not necessarily progressed as much as I'd like us to have.
I had no idea about that if you're over a certain BMI, you can't adopt children. That's just wild to me. That's terrible. Does anyone have anything else to add? Otherwise, looking at the time, I want to leave some room for the Q&A from the audience. If anyone has any last words to add about how the progress we've made.
Yeah, really quickly. Reagan, do you want to speak to the legislation in New York? I could, but I think you're more involved in it. Am I making this up?
No, I'm happy to, but I'm also happy for you to talk about it if you like.
No, you go ahead.
So there is legislation in New York in the city council to protect higher weight people from discrimination. And it's a huge deal. It has the support of the majority of the council. They just did a hearing and that went incredibly well. And so there's actually a chance that New York City will pass this, which would be an incredible step. Some folks know there are some places, like, for example, in the San Francisco Bay Area, thanks to the work of Sandra Solovey, who's an incredible activist within the space and attorney. There are protections there. There are protections in Michigan and some other municipalities, but in general, discrimination against people based on their weight is completely legal everywhere. And so New York is part of a greater push, and NAFA, under the leadership of Tigris Osborne, who's incredible, are doing massive work around this in conjunction with FLAIR, the Fat Legal Advocacy Rights and Education Network. And so there's a big push in New York and then in other places as well to start creating legislation that helps to protect people from discrimination they're experiencing.
I was so thrilled to hear news about the legislation in New York, because I know it's been very recent. So thank you for sharing more information about that. So to take our first question from the audience, it is, how can we improve medical research to include more folks when often those who are marginalized have experienced trauma by the hands of medical providers? Tacking onto this research question, I would also like for those of us interested in pursuing research and having that part of our career, where is obesity research or research on weight currently headed?
I can start if that's okay. I think we have to look at who's doing the research and where's the money coming from. Because when I currently have a study with Dr. Leslie Owen, we're looking at experiences of weight stigma and iatrogenic harm in the highest weight patients who are often even left out of weight stigma research. And so having people doing the research who have some knowledge and some lived experience is incredibly helpful. Something that a lot of people don't know in terms of where, you know, this kind of research is going is that almost all of the money is earmarked only for quote unquote obesity prevention and ending quote unquote obesity, right? So if you want to get money for research, you have to be doing research about how to eradicate fatness, even in weight stigma. And so that creates weight stigma research with the message that, I mean, we don't want to stigmatize fat people, but we definitely want to eradicate them from the earth and make sure no more ever exist, but like in a non-stigmatizing way. And that's not an anti-stigma message under any guise. And so within the research, we have to look at how can we fund research with greater parity? How can we fund researchers who are coming from a place of, you know, non-fat eradication, intersectional justice, and then we create the research from the ground up. And again, it's still going to be flawed because it's in a system that's deeply flawed. But from a harm reduction standpoint, I think those are the places to look at.
Yeah, no, you bring up a very good point, especially given just the structure of our society and with capitalism and weight gain is more and more common. You know, you look at just across the country, it's or how exercise or certain like healthy foods are really expensive, and it just furthers the disparities. Thank you. Does anyone else have anything else to add regarding research in this field?
So I was involved in a project as a layperson. A group in the UK, a big group, had got some money to do obesity research. You know me, this is always going to do this for obesity. I don't believe it's a condition in the first place. And they did this kind of like, they wanted to involve people, lay people, and so they did this kind of like open discussions. You could turn up like 2 hours on Zoom, and they used you know, sticky notes and whiteboards, and it all looked really good. And we kept talking about all of the different kind of issues that impact fatness. And every single time, so say we talked about, for example, the social determinants of health, what I noticed was that everyone always brings it back to our eating and our exercise patterns, because we still have it in our heads, even though this is massively disproven, that it's all about, you know, calories in and energy out. And so what you see is, you know, people talk about, you know, environmental issues, but then they talk about the obesogenic environment. They talk about, you know, access to fresh food. They talk about, they always bring it back to food, and they always bring it back to exercise. Two things that actually are really not all that important. They never mention stress, which I would argue is without doubt the most important thing to be talking about when we're talking about any health condition, and certainly about weight gain. They never talk about, you know, stigma, and they very rarely talk about weight cycling. It's always brought back to food and diet. So I guess, you know, Reagan said it also. I'm just going to say that if it's something that you're interested in, you have to take your mark, you have to exclude, or maybe even say to yourself, let's not even think about food this time around. Let's just not focus on diet and not focus on exercise, and think about the other things. Because this group did this a massive presentation towards the end. This is what our study is going to involve, and we're going to look at weight stigma, and we're going to look at social determinants of health in the context of what children eat and how much children exercise. And you might as well not bother, because you're just going down the same old path and you're not going to be doing anything new.
I'll second that in the context of food access and food apartheid, especially in the Bay Area, which is very quinoa and kale, and I hate it, but that's fine. It is always like people deserve food that is healthy. We have fat Black and brown children who need food, so they'll stop being fat. We don't talk about that in, you know, affluent neighborhoods. White kids are drinking more soda than the Black and brown kids. Like, what are we talking about? It's not the soda, it's not food access. And in the same vein, just like Asher was saying, when we talk about obesity and fatness, it's so easy for us to say it's multifaceted, but like in the solution, let's focus on diet and exercise. It's so genetics, epigenetics, stress, blah. So what we're gonna do is food and exercise. And then the only other thing that I will add as far as research goes is I am working hard, and if anybody is interested, I am looking at people with a BMI under 35 who are accessing gender affirming surgeries, people over 35, BMI of 35, and the people who started with a BMI of 35, lost a bunch of weight to access surgery. What is happening there? So there's a 3-part situation. It's not just the two. And so I am, again, in the Bay Area. If anybody's interested, I would love to partner. I have to create enough noise first in order to get that done.
I can touch briefly on how we talk about research, because I think this will lead into like how to advocate for yourself. So often when we read newspapers or our care providers are talking about us, they're talking about relative risk. So let's look at gestational diabetes, because that seems to be like the main one for people at higher weights during pregnancy is, oh, you're 4 to 5 times more likely to incur gestational diabetes. And you read this in like every article and you're just like, 4 to 5 times. Like, people go into this like so stressed, which we know that stress could, okay, but anyways, so they go so like 40%, 50%, like what does this mean? And when we actually look at the research, the risk is about 17% for those with a BMI above 40, but nothing is, we all have individualized health, right? And there are things that we can do to reduce our risk. So I really encourage people to flip the script. So instead of focusing on relative risk or, numbers that can get people stressed out, say, hey, you've got an over 80% chance of not incurring gestational diabetes. And here are all the other things we can do to help reduce your risk. So reframing, providing evidence-based information, but in a way that doesn't scare people, providing it in a way that empowers people to feel great about their bodies, to know that the odds are on their side, because when you exist in a larger body and you're accessing, especially reproductive health, you just are made to feel like you're a ticking time bomb, which is, so the societal bias, right? And the bias within the healthcare. And so rewriting these messages and helping people to still have conversations, because care providers are still going to need to or want to have certain conversations, but how can we reframe them in a way that empowers people? So that's one thing that I do a lot with plus size birth.
Excellent. Thank you so much for everyone who has shared. We will quickly touch on this next question, and then we have one final question. So 2 more to go before ending at 1:30. We have a question asking, the American Academy of Pediatrics have updated their recommendations on childhood obesity to approve treatment drugs like Wegovy or Lista to children as young as 12. What are your thoughts? We could just maybe spend a couple minutes on this.
I'll say really quick, the guidelines came out on a Monday and I was scheduled to give grand rounds at Minnesota Children's Hospital on Thursday. So I got to become an expert in this super fast and wrote a bunch of pieces on weight and healthcare if you want to kind of dig into it. But the research does not support, that's to say it as quickly as I can, the research absolutely does not support these recommendations. Recommending this to kids this young on 68 weeks of data is unbelievably irresponsible, and the conflicts of interest that exist here, including the fact that the makers of those drugs directly fund the AAP. So not only do they fund about half the doctors who are authors, they directly fund the AAP. And in their disclosure of conflicts of interest, all they said was that the AAP did an independent review and discovered no bias. So there are no disclosures, and they're not in a position to do an independent review because, again, the drug manufacturers whose drugs they're recommending fund them directly and fund a majority of the doctors who wrote the guidelines. So I find these guidelines to be horrifying. I find them to be unethical, and they're not anything that I think anyone should be following.
And just a really quick thing about Wegovy, all the Wegovy trials, I've read all 13 of the ones that have been published. All of them are on predominantly white women. Just so you know, you cannot extrapolate that data to anybody that isn't a white woman, but I guarantee you they are going to be pushing these drugs towards, again, we don't even say which communities, we all know now, right? So even the data is completely flawed. And the data, of course, shows that after taking it for a year, you will begin to regain weight, even if you remain on it. And if you stop it, you will regain weight at such a rate that has never been seen before. But that's it, I'm leaving it there because I can get very angry when we talk about Wegovy.
Understandably, why you would be frustrated with the narrative that they're trying to push and the advertising and the collusion that's going on between these groups that shouldn't have input. I will wrap up with our last question of today. And I will also say that in the chat, we will be putting the social media and where to find more about our lovely panelists today, if you'd like to continue to check them out. But for our last question, a little self-care question, which I think is quite necessary for today's wonderful panel and to close out and looking forward. How do you practice self-care and support your well-being when facing constant weight bias and its associated oppressive structures? What advice would you give to individuals? How can we empower people of all bodies?
I'll quickly go first. I would say first, I think to remember this is becoming your problem. It is not your fault. And so create that space between what you're experiencing and the internalization of that experience. This shouldn't be happening. You shouldn't have to gear up and take workshops to go to the doctor. None of this is okay. this is wrong, it's not you. And then finding ways to get support, finding ways to navigate a really flawed system. And that looks different for different people for a lot of different reasons. But I think for me, the main thing is just to start with, like, this is becoming my problem. This is not my fault. This should never have happened. I should never be dealing with this.
One thing that a lot of the research in weight stigma shows is that people who have a perceived idea of what their body should look like, or their weight should be, actually struggle much more with weight stigma. And one of the things that I enjoy, actually, I think is not, I'm going to say a privilege, but one of the things I enjoy about being trans masc and being queer and being very much not interested in serving the male gaze, not interested in any of that kind of cis hetero patriarchal misogynistic bullshit. Sorry, am I allowed to swear? I did it now. I do apologize if I'm not allowed to. But one of the great things is that actually you get into community, and and you have solidarity with other people, similar like-minded people, who remind you on a daily basis that you're great and that your body's great the way that it is. And I survive I'm very privileged, but I survived by hanging out with really, really cool people, and trying to surround myself with the best of people who get me and who know what's going on. And I'm very, very fortunate to have my best friend lives in Texas. She is a fat Black woman living in Texas, never even left the state of Texas. And when I'm struggling, I just text her, and half the time we're texting each other recipes, and the other half the time we're talking about really serious issues. But that's my tip, my self-care tip. Find somebody who gets you and who will support you and love you as a fat human being.
I love that. And I've wanted to cuss a lot during this conversation because it's intense, right? And one of the things that I've found for me advocating in healthcare, because I've had care providers tell me that when I'm struggling to breathe, maybe I'm just so big that I need to be on oxygen. I've had horrible experiences, but I also know what it's like to be treated with evidence-based compassionate care. So a new thing that I've started doing is, right when the care provider walks in, I say how I'm feeling in that moment. And often it's anxious and scared. And so it gives this human, like, I'm really scared. I've been told, XYZ by care providers, and I'm worried that you won't treat me with compassion. And ever since I started doing this, like, everyone's horrified, right? They're like, oh no, I wouldn't do that. So I shouldn't have to humanize myself at all. But it's made a huge impact. So it's something that I, if you can say how you're feeling in that moment and give that human touch. Again, I wish it wasn't something that we had to do, and fighting really hard to find size inclusive care providers, which is really tricky and difficult, and also comes with a lot of different privileges as well. But I'm finding that there is more of a conversation around this, and people are wanting to put that information, like, I am size inclusive. Now, what does that really mean to them? It means something not always the same to us, but at least there's starting to be a conversation, because at the end of the day, there's money behind all of this, right? Like, we are paying for these services or insurances. But that's just a little tidbit that has helped with also my self-care, because I'm able to vent and share how I'm feeling. And then after any health provider, like, talking to a loved one or having someone to vent with or doing some good self-care is absolutely critical.
The only thing I'll add as a thin is how the thins can advocate for their fat friends. So especially in phone visits, so quick example, a friend of mine got COVID and was really trying to get Paxlovid and was told, all these risk factors, blah, 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 like these are like, why didn't you say your weight on the phone? And was just getting the runaround. And I was like, okay, give me the number. I'm going to go. I did the call, I did the yelling, and it, let my friend rest. And so I've gone to appointments. So going to appointments as well is one way to show up and be able to spot the BS and advocate for your fat friends, your fat family members, etc.
Wonderful. I love that we are ending off with that. This is all of our liberation is intimately tied together. And so it's not just the fight of one community, it's really all of us fighting equally and together for a future that we all feel included and empowered in. So with that, thank you so much to the lovely, lovely panelists, as well as for all of you who showed up and attended today. I hope you enjoyed it as much as I did. In the chat, we will be sending a feedback form. So feel free to share any suggestions or anything that you might have for us, or email us directly if you'd like to learn more about the organization or also have other feedback. We will be hosting the next installment of our storytelling series on fighting stigma against sexually transmitted infections within the coming month. We would love to see you there. And again, thank you so much for coming. Thank you to all of the panelists. Just amazing. We are so appreciative of you taking your time, sharing your stories. And I hope everyone has a wonderful rest of their Saturday. Take good care.